So I don't know, summarizing 2 years in 5 minutes, you call it exciting, I call it nerve-wracking. I'm Director of Collaborative Care at UC San Diego, and I think because of that, I was recruited to be a cluster PI, my role in this project. It's a large pragmatic trial sponsored by PCORI, so thank you very much, where the research question is really, does integration of behavioral health and primary care serve patients better than simply having co-located care? So it's not only can better care deliver better outcomes for patients, but also their intervention, is that going to actually improve integration? So it's a cluster randomized design. UCSD is providing 6 of the 40 different practices that are involved. There's a lot of different issues related to the randomization of patients and practices. But really the intervention is 9 months long, where they're trying to base it off of a Toyota production lean method for quality improvement. And they're providing a coach for each of the 6 clinics during an intervention phase to improve their integration, their level of integration. So the outcomes that are being measured really include not only is the practice improving their integration, practice integration profile is the measure, but also doing qualitative surveys and focus groups of patients and providers. And then the patients, certainly there's going to be focusing on those with complex medical problems. We have just begun the 3rd year of a 5-year trial. And basically half the program, half the clinics are randomized to start now versus a delayed entry. Really what I want to focus on is the complexity of the onboarding process and really understanding what it takes to get practices and busy clinics involved in this. Determining their eligibility, it required actually that there be a 50% behavioral health provider there. I add these slides, not that you're going to read any of this, but just the complexity and the issues that we have to go over in terms of what the clinic is buying into. They really were very concerned, as we're requiring for 9 months their key leaders to be engaged in a process of quality improvement that they weren't really kind of initiating themselves, and being able to kind of make sure that they're very clear of our expectations of them and the buy-in. In fact, one of the things that occupied most of my time for the last 2 years is 12 pages going over a data use agreement, the HIPAA requirements that were involved, certainly IRB issues that were also involved. And again, it's about making sure that you're very clear, more communication than I've ever been involved in making sure that clinics know what they're getting into. Certainly, I've been doing IRBs for a while, and this was kind of the most onerous one that I've ever done, where in fact it required about 14 months of back and forth. Really then a lot of contracting issues, making sure that the practice sites were reviewing and returning, signing the documentation, looking at the welcome package and kind of kicking off things. It also included, shall I say, some prickly conversations about the budget, about what was going to be involved. Certainly the providers were very concerned about their patients' data, but they were also concerned about why would we ever contribute 10% of a person's time for a year without getting adequately compensated. So once this actually was kicked off, I can't even read this. Certainly we had to make sure that a big part of the intervention was to educate all of the providers in the clinic to view videos that were educational and making sure that the information systems were adequate for doing that. Then the first 3 months of the 9-month intervention was having a planning committee or project group where what was interesting, it was allowing each clinic to decide their own project, which was certainly novel for me, but it was always going to be designed for increasing integration and not about a particular patient population. Stage 2 of the intervention was really about then designing what's going to take, how we're going to take care of scheduling, kind of personnel that's going to implement this. And then stage 3, the final 3 months of the 9-month intervention, is actually rolling it out and making sure that it works. Testing, making sure that again, we have the adequate resources to take care of business. What really happened as compared to what was actually intended, we started with one of our family medicine clinics. I actually served as the behavioral health provider as well as the cluster PI, so I had a kind of a dual relationship going on. Given the fact that we had 3 of the 5 key project team members leave, that was a pretty critical thing. And also, what was interesting is they had this lean method, this whole toolkit, 3 70-page manuals, and we gave them an earful about kind of the language they were using already. And that we're looking at how do we actually focus on who is it that this clinic really wants to not only address in terms of patients, but also how is that going to have a sustainable change for integrating services. I'm done.
Nice. Very nice. Again, we have time for one question. Russ.
You kind of talk through kind of all the challenges of implementing it. Kind of, you know, as we've talked a lot about the patient experience, can you talk a little bit about what's a provider experience, and do you think this is a positive provider experience, integrated care? Or
well, so the providers that are involved now are simply the clinic, the medical leaders, the medical directors at each clinic. So it's not all 20 physicians at Scripps Ranch Clinic. I think what the experience so far has been, it's been more of a uphill, a lot of more effort that was involved than they probably originally thought. I can't speak because I'm not that familiar with truly what the quality improvement roles and tasks are at each clinic, but it seemed like it was no one is in charge of kind of designing and making sure that projects are going forward. I think my experience, and I think Dr. Morin at Scripps Ranch, you know, if you just said, do PDSA cycles until you're, you know, blue in the face and kind of improve integration, that probably would have been easier, but it was fairly intimidating to be given 3 different 70-page manuals about how to run a meeting. And so I think there was it was very interesting, because I mean, my role was the liaison between the research team that was primarily at Arizona and Vermont and the clinic teams. And so it was fortunate for me that they kind of chose the One Family Medicine site as a beta site. And so some of the data would be secluded in some ways. But I think the buy-in from the providers, I think is going to be quite a challenge, because just getting very busy physicians to watch 2 hours worth of videos, we have to be very creative of how we incentivize people. The other thing, you didn't ask it, but I think the real struggle for the last year has been between unions and how you can pay people to participate in some of these things and incentivize them. So administratively and fiscally, it's been quite a challenge.